I'm Adrian Brady. I'm the consultant radiologist in the Mris who looks after HHT patients. And for the next little while, I'm going to tell you about what we do and why we do it and what we're trying to achieve when we see patients for clinical screening. So just very briefly to give you some information, apologies to those of you who already know this. I'm sure most of the people on this Zoom call probably are already aware of a lot of this information, but just a quick recap. If we take 100 people with HHT, about 90% will be symptomatic from the nose over their lifetime at some point, and that principally is nosebleeds or epistaxis. About 1/3, 30%, give or take, will have pulmonary or lung Avms, that's arteriovenous malformations, abnormal blood vessels in the lungs. About 10% will have abnormal blood vessels, Avms, in the brain. About 90% at some point during their life will have abnormal vessels in the lining of their gut. That's GI or gastrointestinal telangiectasia. But these are only a problem in about 20% of people with HHT, and that's usually in later life, generally from the 50s on. 70 to 80% of people with HHT will have abnormal vessels in their lung or in their liver, but these are rarely a problem. Only in about 5% are they clinically significant. But if we don't identify and manage and treat the dangerous manifestations, principally the lung and brain Avms, 10% of people with HHT are at risk of dying prematurely or suffering major disability as a result of their condition. By identifying and treating lung and brain Avms before they cause trouble, we can pretty well bring this risk down to that of the general population. So when you come to radiology, if you have had a positive contrast echocardiogram or echo bubble, the first thing we'll do with you is a CT of your chest, of your thorax. And this is one of our CT rooms. This is the table on which you lie. This is the CT scanner through which you will pass. It only takes 3 or 4 minutes to get the CT scan done. It's a very simple process. There's no injection of anything involved. And what we're looking for are pulmonary Avm, so abnormal blood vessels in the lungs. Almost always when we find these in people, they are associated with HHT. There are occasional cases where people can develop PAVMs without having HHT, but they're unusual. Conversely, as I said earlier, about 30% of people with HHT will have PAVMs. The numbers vary from study to study because of the way they're done, but we generally work on the premise that about 1/3 will have them. They're generally relatively stable in size over time, but they can increase in size with time, particularly during periods of life when they're under exaggerated hormonal influence, particularly adolescence or pregnancy. So they're the times in life when they're most likely to enlarge significantly. These are just a couple of pictures from CT scans showing a pulmonary Avm. Down here is the sac or the nidus of the Avm, and you can see a feeding artery and a draining vein. And this is just a view taken from the sides. The feeding artery is the little narrow white streak. The draining vein is the larger one below it. And this is quite a large PAVM. Now, why do we want to identify and ideally treat or eliminate PAVMs? Well, the kind of symptoms that you may develop or the kind of signs you may have from these include breathlessness or fatigue on exercise. And that's usually only if you have large numbers of them or if they're very large. Most people who have small ones will not suffer any breathlessness or any reduction in exercise capacity. Cyanosis is blue or purple lips and blue peripheries because you're not getting enough oxygen into the blood. And that's usually only in a setting where you have very many PAVMs or extremely large ones. So we very rarely see people with that. Hypoxemia is that state of reduced oxygen tension in the blood, but again, only in large ones. Hemoptysis is the medical term for coughing up blood. That can happen in people with HHT and pulmonary Avms. Massive hemorrhage is unusual, but not completely unknown. It does happen, unfortunately, in rare cases. But the principal reason why we try to identify PAVMs and treat them relates to the neurological symptoms, the symptoms that affect your brain. And that is because pulmonary AVMs offer a channel through the lungs that allows blood clots or bacteria to pass through from one side of the heart to the other. Ordinarily, blood clots or bacteria would be filtered out within the lungs and not cause any harm. But if you have a pulmonary AVM, you have an abnormal channel that allows them pass through. And as a result of that, they may travel off from the left side of your heart to the brain and cause a stroke, or a transient ischemic attack, which is a stroke-like symptom that comes for a brief period of time and goes away. Or more rarely, if we're talking about bacteria, can cause a brain abscess. So over a lifetime, 30 to 40% of people with significant pulmonary AVMs will suffer TIAs or strokes. About 5 to 9% will suffer brain abscesses if they're not treated. The other thing that can result from pulmonary AVMs is migraine. Not everybody with migraine has HHT or PAVMs. Equally, not everybody with HHT who has migraine that is related to pulmonary AVMs. But we do know that the risk of your having migraine is doubled if you have pulmonary AVMs, and the severity of your migrainous headaches tends to be worse if you have substantial untreated PAVMs. In general, the symptoms you can expect are greater if the pulmonary AVM is larger than 2 centimeters in diameter, if the feeding artery is larger than about 3 millimeters in diameter, or if you have multiple PAVMs. It's very unusual, but not completely unheard of, to have any symptoms from PAVMs before adulthood. These are just some pictures of a brain MRI with small black dots representing tiny microstrokes as a result of a PAVM. This is a CT brain showing a brain abscess in somebody who had a PAVM. Now, these are some pictures that I often use to explain to patients what's going on with PAVMs. You don't need to get hung up on the simple or complex features of these, but there are things that matter to us if we're treating them. But essentially what you've got in any PAVM is an artery feeding blood into it, a sac or nidus, and a vein draining blood back out of it. So if we can block off the inflow and make sure that no blood is getting in through the artery, then this PAVM should scar down and is no longer part of the circulatory system, and therefore the risk is eliminated. So the possible outcomes of screening for PAVM. If your echo bubble is negative, and I'm talking here about adults, then we don't do a CT because a positive echo bubble is a very, very sensitive test for the presence of pulmonary AVMs. If it's negative, we don't need to follow you up. We can take it that you almost certainly do not have any pulmonary AVMs. On the other hand, if your echo bubble is positive, that suggests to us that you may have pulmonary AVMs. Doesn't mean you automatically do. There are other reasons for a positive echo bubble, but you may have. So we will always do a CT thorax in people with a positive echo bubble. If that CT shows us no PAVM, we work on the presumption you have microscopic ones we can't see, and we'll repeat the CT in 5 years to see if they've grown. If it shows very small PAVMs that are below the threshold at which it's possible or necessary to treat, then again, we'll follow you up with a CT, usually after a 5-year interval. If we see a larger PAVM, we will try to eliminate that from your circulation, usually by embolization. Then we do a CT 6 months afterwards to see if we've been successful. And then you go on a 5-year follow-up cycle of CTs. Now, how do we deal with pulmonary AVMs that we identify that are of significant size? Well, if the feeding artery is greater than about 2.5 to 3 millimeters in diameter, it's been shown that it is worthwhile to try and embolize them, block them off, so that they go away essentially, and the risk of embolization is removed. Before 1980, this involved surgery, removing bits of your lung. And obviously that could only be done once, twice, or a very small number of times, because with each subsequent operation, you were losing more and more lung capacity. This man, Werner Portsman, a German interventional radiologist, first described embolization in 1977. And this is now the universal first line of treatment for pulmonary AVMs. and it's what we always do. And embolization means essentially blocking off the inflow, the arterial inflow, with balloons or coils or plugs, shutting down the circulation to the pulmonary AVM without damaging any of the normal surrounding lung. We know that if we can embolize all PAVMs with feeding arteries of greater than 3 millimeters in diameter, we can give you very substantial protection against bland embolization. Bland embolization means clots that are not infected passing through the PAVM and potentially causing stroke. Embolization of these PAVMs does not necessarily protect against bacterial embolization, small bacteria getting through tiny PAVMs. So for that reason, we advise that anybody who's a positive echo bubble, whether we've identified pulmonary AVMs or not, should always have antibiotic prophylaxis for dental procedures. And I'll talk a little bit more about that in a moment. How do we do embolization? Well, we put a catheter usually in a vein in your right groin, the femoral vein, and we thread it up through the veins in the right side of the heart into the lungs. And we use various different methods to block the blood flow into the pulmonary AVMs. Usually we use these coils. They're platinum coils made by a company called Cook, Nestor coils. And the idea is that we pack them into the feeding artery such that they will block any blood getting past. So this is a diagram of how that works. We'll have a catheter as close to the PAVM as we can, and we push the coil out the end of the catheter and pack it in tightly to block the artery completely. Sometimes we use other devices. This is an Amplatzer plug that I use in larger PAVMs. It doesn't really matter. From your perspective, the end result hopefully will be exactly the same. We block the artery. So this is a nice example from some years ago. This is the patient's chest x-ray showing a big PAVM down in the left lung. On this CT scan, you can see two dots. One represents the feeding artery, the other the vein draining away from the PAVM. And a little bit lower down, that's the PAVM itself. You can see it also on this image, which is just photographed differently. So what we're trying to do is block that feeding artery. This is an image from a pulmonary angiogram. That's the test we'll do with a catheter in your vein, pass through the heart and into the arteries in the lung. We inject dye, and that will show us the arteries in your lung and the PAVM and the draining vein if it is there to be seen. So getting a little bit closer to it, this is the tip of the catheter. This is the feeding artery, which branches in two with a big sac or a big nidus. And then a moment later, we see some filling of the vein draining away from it. We don't need to do anything about the vein or the nidus. What we need to do is block the inflow. If we can block the supply coming in through the artery, then this will all scar away and go away, and the risk goes away with it. And in this particular patient, you can see the catheter in the feeding artery here. I'm pushing out coils, and by the time we finished, I had placed 8 coils in total, blocking that feeding artery. And when we injected some more contrast, some more dye to see if that blockage was complete, it was. Nothing was getting past them. So this was the patient's CT before embolization. 9 months later, CT in the same position shows that the nidus of the PAVM has scarred down. In other words, embolization was successful. There was no continuing blood supply to it. And we can be happy that that patient's risk from that particular AVM of stroke was effectively eliminated. So that's what we seek to achieve. Now, I mentioned antibiotic prophylaxis. Anybody who may have a PAVM, in effect, anybody who has a positive contrast echocardiogram or echo bubble, whether we see a PAVM on CT or not, anybody in that situation should always have antibiotics prior to any dental treatment that might cause bleeding in their mouth. We know that in patients with pulmonary AVMs, the vast majority of brain abscesses that occur are as a result of infection with organisms that live in your mouth, normal organisms that are introduced into the bloodstream, usually during aggressive treatment, dental treatment that might cause a little bit of bleeding. So for that reason, we advise that every patient who may have pulmonary AVMs should have antibiotics before such treatment. Usually, we recommend a combination of amoxicillin and clavulanic acid or clindamycin if you have a penicillin allergy. Dentists would usually be very familiar with this. If you're attending your dentist and they want any further information, we have information we can send out to them. One point to make is that occasionally we get inquiries from dentists who say, oh, those guidelines have changed, that's not necessary anymore. What they're referring to is a different circumstance. In the past, it used to be recommended that anybody who has an artificial heart valve and is having dental treatment should have antibiotics. That guideline has changed now, but that is targeting a completely different danger and mechanism. The guideline for patients with pulmonary AVMs remains the same. You should still have antibiotics. But as I said, if your dentist has any concerns or any questions, we're happy to provide further information. The other thing that anybody who may have a PAVM, in other words, anyone with a positive echo bubble, should always be aware of is that scuba diving is a bad idea. Scuba diving can cause nitrogen bubbles to form in your blood. They can act as clots and cause stroke by passing through a PAVM. So we generally advise that people with PAVMs or with positive echo bubbles do not engage in scuba diving. So just very rapidly to run you through again what we do with PAVMs, we do a contrast echocardiogram. If it's negative, we stop. We assume you don't have any PAVMs. One little proviso is that if we're doing this in a child, we may repeat the echo bubble after or during adolescence when the child has grown a little bit. But if we're talking about somebody older and the echo bubble is negative, that's all we need to do. If it's positive, we do a chest CT. If that shows no PAVMs, we presume the presence of microscopic ones. If it shows tiny ones with feeding arteries below 2.5 millimeters, in either of those circumstances, we do a follow-up CT every 5 years to watch for PAVM growth. And the patient should have lifelong antibiotic prophylaxis, as we've just discussed. If the PAVM that we find is larger with a feeding artery of greater than 2.5 millimeters, we'll bring you in for a pulmonary angiogram and embolization. After that, we'll do a CT 6 months later to confirm that the embolization has been successful. And then you go on the 5-year follow-up protocol, again, with the need for lifelong antibiotic prophylaxis. Those intervals may change with time. They've been under review recently. In some circumstances, we may not need to repeat CTs as frequently as 5 years. We are working on whether those intervals can be changed, but for the moment, this is the protocol we follow. Now, the other aspect of the radiology screening that you'll have will be an MRI of brain. Usually that's done on the afternoon or late morning or early afternoon of your visit. This is the MRI scanner. It's a bit like the CT. You have a table you lie on and there's a tunnel, but the tunnel is a bit longer. And you'll spend about 15 minutes in that tunnel while we scan your brain. We'll also give you a small injection through the IV line that you had put in on the morning of your visit for the echo bubble. So the same IV line is used and then we take it out afterwards. And what we're looking for on the MRI is a cerebral AVM or CAVM, an AVM in the brain. And these are just some MR images. The black dots that you see here and here, which show up white after we give contrast, represent a small cerebral AVM in this patient. So the screening and management for brain AVMs, we do a brain MRI in everybody, without and with contrast gadolinium. If we see no cerebral AVM, we stop. If we see a cerebral AVM with a small nidus, with a small sac, you'll probably just be followed up with MRI. If we see a larger one, treatment will be considered, and that treatment will be either embolization, radiosurgery, or open surgery. All of this will be done by specialists outside the Mercy, neuroradiologists or neurosurgeons. And it is those people who will determine the follow-up frequency, if any is necessary for MRI. But if we find cerebral AVMs, we will refer you on to the appropriate people to advise you on what treatment, if any, is necessary. Why do we repeat CTs and not repeat MRIs of the brain? Fundamentally because pulmonary AVMs grow over time. Cerebral AVMs tend not to. So they're either present or they're not. So a one-off screening is adequate unless we find one and we need to follow it, and that's unusual. but people who have positive echo bubbles and very small or no visible pulmonary AVMs may over time develop AVMs that are large enough for us to treat. So we do need to follow you with CT, but the MRI brain is usually a one-off for most patients. What do we do about children? We generally start clinical screening, and by that I mean screening for cerebral and pulmonary AVMs around about 12 years of age. The principal reasons for this are that before that we find children are frightened by the process and cooperation is much harder. But generally we'll start the clinical screening when children are old enough to work with us on that and not be scared of the whole process. There are some things we can do in younger children. If we're very worried about the possibility of a pulmonary AVM, we can check the oxygen saturation in different positions to see if it changes, but we don't use that an awful lot, and it's not a very sensitive test. What we frequently do with young children in families where we know HHT exists is genetic testing, which will at least allow you to determine whether any given child has HHT or does not. Now, a few words about genetic testing. If we do genetic testing, which is basically done with a simple blood sample, that will identify more than 90% of the genetic mutations that are associated with HHT. And the common ones, the three common ones, are the endoglin, the ACVRL1, and the SMAD4 mutations. And I'm sure many of you on this meeting will be quite familiar with all of this and know what mutation you or your family have. Mutations are consistent within a family, so if somebody in a family has HHT and we identify their mutation, all other family members in that same family who have HHT will have the same mutation. If you're positive for a mutation, any child you have has a 50% chance of having HHT. Doesn't matter whether it's a boy or a girl, the risk is the same. It's a 50-50 chance with any child. If genetic testing is negative, if we test you for the relevant mutation and we don't find it, that usually means you don't have HHT, especially if we know what the mutation is in your family already. So if your mother or father has HHT and we've tested them and we've identified their mutation and we've checked you for it and you don't have that mutation, you don't have HHT, you don't need to worry about it. A very, very small subset of people who we think clinically have HHT but in whom we can't find the mutation may have one of the unusual mutations. We know there are at least 7 and there may be more, which are not part of the standard testing. So there's a tiny possibility you may still have HHT with negative genetic testing, but that doesn't apply if we know your family's mutation already and you don't have that. Negative genetic testing does not completely exclude HHT other than in the circumstances where we know the family mutation and have checked you for that. Another important point is that genetic testing does not substitute for clinical screening for PAVM and CAVM. It's a test to determine whether somebody has it or not. Doesn't tell us what the manifestations are in that given individual. So we still need to do the clinical testing to protect you. A few words towards the end about COVID-19. What are the specific implications of having HHT for COVID-19? Not very many, in fact. The principal one is that if you are being swabbed, if you're being checked to determine whether you have COVID-19 or not, you should only have a swab taken from the back of your throat. Normal swabbing is done with a swab up your nose and in the back of your throat. But in people with nosebleeds from HHT, putting a swab up your nose may cause a nosebleed, and that, as most of you will be well aware, can be difficult to control. So we advise that if you have HHT and you're being swabbed, that you ask only to have a swab taken from the back of your throat. The sensitivity is a little bit lower, but it reduces the risk of you having a substantial nosebleed. Beyond that, there is very little about HHT that changes you from a member of the general public with respect to COVID-19. Does having HHT increase your risk of getting COVID-19 or your risk of getting a very severe version of it if you do get it? No, it does not. You're no different from anybody else in the general population. Some of the vaccine package inserts advise that if you have a bleeding problem, you should inform vaccinators. Does HHT constitute a bleeding problem in this context? No, it does not. What they're really trying to capture there are people who are more likely to bleed at the injection site. And that would usually be people who have other blood diseases that would make them more likely to bleed in general, or would be on drugs that might make them more likely to bleed. So if you have hemophilia or von Willebrand's disease, which are blood disorders that promote bleed or make bleeding more likely, or if you're on aspirin or anticoagulants or antiplatelet drugs for other reasons, then you should inform them. But HHT itself, of itself, does not constitute the type of bleeding problem they're trying to pick up here. One very, very, very small subset of people with HHT who have severe liver AVMs, and as a result of those may be in liver failure, would have a slightly increased risk of bleeding. But that's going to apply to a vanishingly small number of people with HHT, and they will already know about their risks. Does having HHT mean you're entitled to priority vaccination? Unfortunately, no. You're not even immunosuppressed as a result of HHT. Therefore, your ability to handle an infection is the same as anybody else. You're a member of the general population. Does having HHT mandate a specific vaccine? In other words, if you have HHT, should you get vaccine A as opposed to vaccine B? No, that's not the case. Again, you will be treated as a member of the general population for your age group and given whatever vaccine is approved by NIAC and NEFIT at the time. And finally, does having HHT increase your risk of having an adverse reaction to any of the vaccines that are out there? No, it does not. Again, your risk is no different from any member of the general public. So that's all I have to say to you today, but we're very happy, Margaret and I, to take any questions that the audience may wish to ask us during the session or afterwards. I think Dara is planning to collate any questions we're not able to deal with today, and we'll do our best to deal with them in writing afterwards. So thank you very much.